Urinary tract infection. Key points. Signs and symptoms of urinary tract infection, UTI, can be nonspecific in young children. Collecting urine to exclude UTI is not required if there is another clear focus of fever and the child is not unwell. Urinary dipstick is a useful screening test, but a positive urine culture with pyuria confirms the diagnosis. Oral antibiotics are appropriate for most children with UTI. Children who are seriously unwell and most infants under 3 months usually require 4 antibiotics. Seriously unwell children, those with renal impairment, and boys and LT 3 months of age should have a renal ultrasound prior to discharge to exclude renal tract obstruction. Background. Signs and symptoms of UTI can be nonspecific, and overlap with common viral illnesses, especially in younger children. A urine sample is required to diagnose or exclude UTI where clinically suspected. Consider UTI if fever without focus persists after 48 hours in young children. Assessment. History. Infants and preverbal children often present with nonspecific symptoms such as fever, vomiting, poor feeding, lethargy and irritability. Older children may present with more typical symptoms such as dysuria, urinary frequency, lower abdominal and loin pain. Ask about previous UTI. Examination. Examination may be normal in UTI other than the presence of fever. Lower abdominal or loin tenderness may be present. Nonspecific findings include dehydration and lethargy. Assessment of severity. Clinical distinction between lower and upper UTI can be difficult, especially in younger children. Cystitis is suggested by features such as dysuria, frequency, urgency and lower abdominal discomfort. Pyelonephritis is suggested by systemic features such as fever, malaise, vomiting and loin tenderness. Management. Investigation. Children with suspected UTI should have a urine sample collected. Dipstick and microscopy screening can guide initial management. Check culture results after 24 hours to confirm or adjust management as appropriate. Urine samples should be collected prior to starting antibiotics, unless the child is seriously unwell and requires immediate therapy. Older children able to void on request can provide a midstream urine sample. For younger precontinent children, a clean catch is often suitable. Catheter or spa may be required for seriously unwell infants. Urine collection. The perineal/genital area should be cleaned with saline-soaked gauze for 10 seconds before collecting midstream or clean catch. Urine. Midstream urine, MSU. Preferred method for toilet-trained children who can void on request, contamination rate 25%. Clean catch. Appropriate for precontinent children who cannot void on request, but are not seriously unwell, yield may be blank. Appropriate for precontinent children who cannot void on request, blank. Suprapubic ASPI rate. Gold. Standard contamination rate 1%. In/out catheter. Useful if there is little urine in the bladder, such as after failed clean catch or spa. Discard first few drops of urine if possible to reduce contamination rate 10%. Bag urine. Not recommended for culture due to high false positive rates, contamination rate 50%. Urine dipstick. Urine dipstick is a useful screening test to guide initial management. The presence of leukocytes and nitrites is suggestive of a UTI. See notes section below. Dipstick results are less reliable in neonates and young infants, particularly due to false negatives. Urine microscopy and culture. Laboratory microscopy can complement dipstick results to guide initial management. Bacteria and leukocytes on microscopy are suggestive of UTI. See notes section below. Epithelial cells, squams, suggests skin contamination and a poorly collected sample. Consider recollection. A positive culture with sufficient growth and pyuria confirms UTI. Growth of a single organism at and GT10. CFU/liter, and GT10. CFU/ml, from any collection method suggests infection. Growth of a single organism at lower counts of 10. CFU/liter, and GT10. CFU/ml, from catheter or spa urine suggests infection, and from clean catch or MSU may indicate early infection. Growth of any amount from spa suggests infection. Other investigations. Check renal function and consider renal ultrasound if the child is seriously unwell, or not responding to appropriate therapy after 48 HRS. Blank is blank. Check renal function and consider renal ultrasound if the child is seriously unwell. Treatment. Oral antibiotics are usually appropriate. Any child who is seriously unwell, and most infants under 3 months, should be admitted for initial 4 antibiotics. 3-7-day course for children with cystitis. 7-10-day course for children with pyelonephritis. Oral treatment. Cephalexin 33 mg per kilogram, max 500 mg, oral BD. For pyelonephritis, cephalexin 45 mg per kilogram, max 1.5 g, oral TDS. For treatment. Do not delay antibiotic therapy for a child who is seriously unwell, even if a urine sample has not been obtained. Blank. Guideline. Check gentamicin levels and renal function before third dose if continuing gentamicin beyond 48 hours. Switch to oral antibiotics when clinically improved and/or as soon as tolerating oral antibiotics. Follow up. Seriously unwell children, those with renal impairment, and boys and LT 3 months of age should have a renal ultrasound prior to discharge. Other children do not require an ultrasound for a first UTI. A non-urgent renal ultrasound should be arranged for children who have recurrent UTIs. Routine antibiotic prophylaxis after simple UTI is not required. Specialist follow-up should be arranged for children with recurrent UTI or known renal anomalies. Consider consultation with local pediatric team when child under 6 months of age. Child has known renal tract anomalies or not responding to initial therapy. Treating any child who is seriously unwell. Consider transfer when any child requiring care beyond the level of comfort of the treating hospital. Consider discharge when tolerating oral fluids and antibiotics.